Currently, Femi Arowolo is a clinical specialist and lead occupational therapist at United Lincolnshire Teaching Hospital, Boston, United Kingdom. So that alone shows you that today's presenter has deep knowledge about occupational therapy. So if you pay attention, you will get to learn a lot. So don't forget, once again, the title of the presentation is Inclusive Education for Children with Muscular Dystrophy, the role of an occupational therapist. So, Mr. Arowolo, over to you. Thank you.
Thank you, Ofon. Thank you very much. And everyone, I welcome all of us to this very important presentation. So FSOT is my alma mater. I graduated in 2008. We were the fourth set in the school. So yes. Right, today we'll be talking about inclusive education for children with muscular dystrophy in Nigeria. So much of what I'll be talking about will be what we think should be obtainable in Nigeria. All right, of course, if we are to talk about what is obtainable elsewhere, where you may be looking at it as a far-fetched approach, yes. So we will just bring it down to what we be able to do or advocate for within Nigeria. Right. The objective for the presentation, we won't be talking much about muscular dystrophy. We will not be talking about muscular dystrophy as such, because thank you, Obi, for doing justice to the introduction to muscular dystrophy. So we'll talk about education, the context of Nigeria, and then explore some evidence-based OT roles in schools. Then also talk about a little bit of data gap within Nigeria, and talk about how we can promote the advocacy and collaborate with the leaders in power. I know some of you students, you have powerful people, your parents who may be into politics, and who we can leverage on their involvement in policy making to advocate further for the inclusivity of the educational system in Nigeria. At least you can leverage on this knowledge to do that. So understanding muscular dystrophy, yes, Obi has done justice to this. It's a group of inherited neuromuscular disorder causing progressive muscle degeneration. In my practice, I've not come across so many muscular dystrophy type other than the Limb-Girdle and the Duchenne muscular dystrophy, basically. I've read about others in textbooks, but physically talking about coming across them, yes, it's not so many. So it leads to weakness and fatigue, loss of ambulation, and reduced endurance. And it also affects the ability to participate. Participation is something that we hold very high in occupational therapy. So your daily life, from waking up to sleeping, and if you are unable to do all these activities, that's where occupational therapists actually thrives. Right. So looking at the context of Nigeria and the global. So Duchenne, which is the one I'm actually focusing more on, it affects 1 in 3,500 to 5,000 male births globally. And the major problem we have in Nigeria is underdiagnosis, as Bobby rightly said, that many people prefer to go to the religion houses, to the native doctors, instead of getting the actual diagnosis. We have a lot of people in our communities who are affected, but they still don't know what it is. So for some of them that are already diagnosed, they are still limited testing to know which type of muscular dystrophy they've got. So they just give them umbrella diagnosis of muscular dystrophy, but the type actually will determine what to expect in terms of limitation, functional limitation, the future functional limitation that we should be expecting. So there is still limited data, there is no registry to show the number we have, and late diagnosis actually is more common, because many of them must have damaged a lot of things trying to do one thing or another before they realize exactly what the case is. So this also requires attention at the policy making level, right? So I'll be looking at the impact, because as Obi rightly said, we are not looking at the diagnosis itself. It is the impact that this diagnosis has had on individual. That's what we as occupational therapists are focusing on, right? So we are looking at mobility, we are looking at how it affects because this is about school, about supporting this individual in their education. Because many of them, because of the weakness they've got, their parents would rather start thinking about maybe special school. If I must shock you, many of these children can actually attend regular school. They can attend any school, because mostly their cognitive function are preserved. Or maybe we have some rare cases where it affects their cognition, but mostly they have their cognitive function preserved. And that way, they can attend any regular school. All we just need is what we are about to talk about, what we need to do to ensure adequate participation in school. Right. So we have fatigue. Sometimes they have psychological challenges, which we'll be talking about, stigma from bullying in school and every other thing, even bullying from family members, even from parents. It happens because they lack the understanding that is required to take care of these children. Now, we can't advocate for inclusive education without knowing what it actually means. So, it is an education that accommodates, the system that accommodates all learners, regardless of their disability. So, it's about access. It's about participation. Because without access, without participation, you can't achieve anything. So, we will be fusing all of them together. For you to have an achievement in your education, there should be access. And that access will allow participation. So, because this is a recognized human right, we all know, maybe in Nigeria, people mostly don't read about their rights, but we encourage you students to try to know what human rights are, especially around education. So, because UNESCO 20 actually recognized this as fundamental human right, access to education. So this is to promote equity, dignity, and independence, so that in the end they will not be on the wheelchair outside asking for alms. Right. So let's continue. So looking at the inclusive education in Nigeria, when we make education inclusive, it also supports the Education and Disability Act in Nigeria. If we all know about this policy, it's something that we as occupational therapists should know, because that is how we can advocate for people. So implementation gaps is still very poor. Even if we know the policy, it's not implemented. So if you go to many schools, I remember I did my final year project in the university, SRM back then, was about access to university by people who use wheelchair. We have limited trained specialists among us. You know, the little number of people that are being trained currently in Nigeria, we are coming out to look outside and, go around and leave the country. It's still affecting our educational system. And that's why we have you coming up now to play your own role as you're coming out to ensure that the policy is reaching the people involved. So we will be needing stronger school-based rehabilitation to be integrated into the system. And it starts with all of us. Even if eventually you're going to have to, nobody wants to remain stagnant. If eventually you want to further your education, you want to grow in the career, you must leave your impact. Ensure that what you know is transferable. You've transferred it to the people on ground, educate parent, teacher, and everyone, so this advocacy can be fully integrated into the school system. So why do we need inclusive education for muscular dystrophy particularly? So participation is very important. And what we call social inclusion. I know we talk about this all the time for some of you that are already doing pediatrics in school. they talk about social inclusion. Yes, social inclusion will mean that everyone can live together regardless of what is wrong, regardless of the condition that you have. You should be able to function among people, doing your daily life activity without prejudice, without anybody thinking you are a little less than what you should be. So you should be able to function maximally. If the environment is adding to your problem, maybe there are barriers, there are built barriers, there are natural barriers, these barriers must be removed to promote social inclusion. Right. Then when you have good social inclusion, it enhances your self-esteem. Because when you have self-esteem, that is when you can have retentive memory. Good self-esteem will enhance retentive memory in school. When you learn something, you can retain it. You are not worried. You are not troubled about bullying, about what people are thinking about you as an individual. And it also reduces stigma and discrimination. And eventually it supports long-term quality of life, because this is the whole essence of actually doing this whole inclusive education thing, quality of life. Because even if you as a neurotypical person, if you have all the education you have and it doesn't translate to improved quality of life, then all the education will be a waste. So that's why we are advocating for this, for the individual with MD. Now, that comes our role. Everything I've just talked about are basically about advocacy, about getting the right set of people involved and, moving forward, and the knowledge we need of all the policies and acts that is available within Nigeria. So this is the role of OT. We, as OT, we enable participation in meaningful activity, right? As the definition of OT implies. We use activities, we use everything that is meaningful to this individual. Play, we use the daily task, we use mobility, all sort of things, art and craft, to ensure that activity is enjoyable and is involved what this individual consider meaningful. Then it also promotes independence and functional performance. We also adapt tasks and environment. We support teachers and family, and also advocate for inclusive school system. That's where we are going. Even if we are going to do only inclusive school system kind of occupational therapy, we need to also look at the life of the individual from home to school. Because when there is no support at home, when this individual is having challenges at home, dressing for instance, because school activity doesn't start only when this individual gets to school. It starts from home. When this individual is able to dress themselves, they're able to complete their assignment at home. That translates to good performance in school. So that's why we have to look at the life of an individual holistically before we now bring everything down to the school activity. So we cannot do anything without assessment. The most important part of our intervention is assessment. So around the school, what we assess basically is the functional mobility and positioning. We start with that. Functional mobility, because if you cannot mobilize, you can't get from home to school, how do you participate? So these include sitting and posture assessment, navigating hallways in school, classroom, playground, and restroom. These are important areas in school where we, as occupational therapists, need to look into before we start our intervention. Because if you must get a child to school, you must understand that the environment is very important, because they will be interacting with this environment. Right. Then there comes fine motor and handwriting skill. They will need this. Of course, we know for some, this will deteriorate with time because of the loss of motor function, right? So we need to look at pencil grasp. I believe we all know about hand function. We are not going to go deeply into this, because hand function on its own is a topic that will take a whole day to treat. So yes, we will not go into that. Then we look at handwriting, we look at grasp, speed, and the legibility of their handwriting. Or I include use of scissors, because in writing, using scissors is very important, because it involves the fingers that we use in writing, basically, the 3-point writing. So when you are using scissors, it also includes those fingers. That's why I include it. So it could be an activity that you will use to improve fine motor function before you start writing activity. Then we need to also look at fatigue and endurance and activity of daily living in school. We do activity of daily living in school. So like dressing, if you want to go for sport, or maybe you go to the toilet and you need to dress again, then tying shoelaces, as simple as that activity may be, it's very difficult for people with poor hand function. So we must look into that as part of our assessment. Then environmental accessibility audit, very important. As I said, I did something like this while I was in the university, looking at the door width, because some of them will be coming to school with a wheelchair. So these are very important. We'll be seeing some of these as we move on. After that, we then need to look at intervention. These are some of the interventions that we consider as evidence-based. Energy conservation. We must have heard about this for some of us in year 2. You must have heard about energy conservation, using rest and breaks, minimizing unnecessary walking for some of them that are still on their feet, then scheduling high tasks earlier, because people are stronger in the morning, and as the acetylcholine is beginning to decline, please kindly mute. And yes, as the acetylcholine is beginning to decline towards evening, people get tired. Normal, regular people, day to day, they get tired. When you talk about people with muscular dystrophy, it's even a little challenging for them. All right. Now, looking at adaptive sitting in classroom as part of our evidence-based intervention, I'm sure some of us are aware about ergonomics. This is very important for people with muscular dystrophy. Sitting surface, the Alexandra technique sitting posture is very important. So supportive sitting, you need to look into that in classroom. The height of the chair, the height of the table, the position of their elbow when they are writing is very important. So those things we need to look into. Specialized sitting in class, foot rest. Many of these individuals are unable to move their lower limb, to dislodge fluid and, help in circulation. So position is very important. We can't go into the details about this, but it's something I will be glad to answer a question on if there's any question. All right, assistive technology and writing aid. This is also very important. In handwriting, slant board. This helps with wrist alignment. When they are writing, instead of resting on the elbow directly, the slant board will help them to write with just minimal elbow support on the table, while then the slant board will will support their wrist in this position. So it's easy to write. Then pencil grips, laptop or tablet. Of course, I know this might not be obtainable in some school, but this is something we can introduce to the government, the policy maker, because I know now educational institutions are trying to develop the way they teach, so they are going digital. So in this case, yes, tablet, laptop will be very useful. Then speech to text software, which are now available, they can use it to take notes in class, and they can also use it to complete their assignment when they are no longer able to use pencil, because of course we know that these conditions sometimes will diminish in time, and at some point writing may become very challenging or tiring, or maybe too fatigued to write. They need to continue to do what they need to do, and that's why we are occupational therapists. We don't stop functioning even if the condition is becoming too difficult to manage. Then environmental modification, as I said, very important. As you can see in that picture, it's very easy for anyone on wheelchair to access this classroom, right? So ensuring ramp and wide doorways and accessible toilets are available, right? I'm not sure about what the toilet in many of the primary schools in Nigeria look like. I remember when I was back in Nigeria, the school might unattended. You have to go about 2 flights of stairs to get to their class. So there was no ramp access, no lift, nothing. These are the things we need to start looking into as OT. You don't have to find a job in a school to get involved. As part of the advocacy, when you visit a school, maybe your former primary school, formal secondary school, you can use it as a project, as something to visit the school and talk with the school leaders, see what you can do to support as a way to give back to the community. And that way, you're already preaching the gospel of occupational therapy to those who don't already know about it. All right? So, self-advocacy and independence training. Yes, this is very important for the people. And I understand that this is what brought the founder of this advocacy, our host, that's what brought her to this level of understanding of muscular dystrophy. That's self-advocacy. And this is very important that we teach it to the people involved. Teaching the child to communicate their fatigue, to understand how to take break, to know when to request for help. This we must teach them, not to keep the children in the dark about what is happening to them. Many of them will say, oh, don't want to let them know. They'll keep lying to them that, don't worry, you will be all right. This thing is just temporary. You will be fine. And then they have that false hope. We need to start building them up. I know it's hard, but it is something we can do. We start from the beginning. So we build organizational skills into their entire daily life, to be able to manage themselves, and then encourage peer interaction. Some people who are living with this condition are everywhere. We can link them together to, teach each other how they cope with their condition. And this will, make them feel that, oh, after all, I'm not alone in it. It's not something we pray for, but it happens. So we link them up. So helping the child to understand their strengths and limitations is also key. And also preparing the child for transitioning, because they'll be going from primary school to secondary school, and it's a whole lot of experience put together. And by the time they get to the university, it is becoming too challenging to cope with because of the rigor of what they have to go through in daily life, traveling from home to school. Right. There are so many assistive technology available to support this individual, ranging from wheelchair to writing material and, text-to-speech software that are now available that we can begin to introduce to them. Thank God we have the internet where, we have so many studies that show the benefit of all these tools. And they may be expensive, and this is also where we have to work with the parents, work with the school, the policymaker, the government, look for grants, talk to those we can talk to, ensure that these things are inculcated into school system. A school does not have to have a child with disability before they implement this. They should make them available so that this will encourage parents who are already thinking of taking their children out of school to be able to access regular school system. Right. We are not alone in this as occupational therapists, because this we can't do alone. So we must know those that we are supposed to work with. As I've said, the teachers are there, the school administrators, the parents and caregivers. They are the most important part of this whole thing, because it is their belief that will also help the children. Many of them, they believe that, if I pray, yes, prayer is effective. Don't get me wrong. But we also encourage people to pray, because faith is one thing that keeps the parent going. When they lose faith, they lose everything. So, but while they pray, we also need to emphasize the importance of education, understanding what the condition is, the progression, and the life expectancy and quality of life that this individual can lead if early intervention is encouraged. So physiotherapists also, they are very important as OT, even as physicians, because maintaining the muscle integrity for as long as possible is very important. As I always said, people say, oh, don't know the difference between physiotherapists and OT. Yes, physio will help the patient move, while we help the patient perform. Because whatever you do with the movements you are making, bend your hand, that's not enough. Until you are able to use that hand that you're bending to put food in your mouth, it is not complete. So putting food in their mouth is our own as occupational therapists, while just bending and making sure that the joint is mobile is the work of physio. And then they continue like that. We have to work collaboratively until we ensure that this individual is functioning maximally. And prosthetists and orthotists, they are very important. As Bobby mentioned earlier, that sometimes there will be muscle contracture, especially if adequate range of motion exercises are not emphasized on daily basis. That's when we need prosthesis. Of course, we use prosthetics for prevention of contracture, so don't get it mixed up. We prevent contracture. We also treat for some of them that already have the contracture. We, serial casting, serial splinting to ensure that the joints are malleable again. Right, I'll just give a little brief case example of a 10-year-old. I just need the student in our midst to interact with us. If you can unmute, please. If you need to answer based on what you've just heard. So a 10-year-old boy with Duchenne MD in mainstream school. I know we understand what mainstream school is, the regular school we have around us. So the challenges are there are stairs in the school. The child gets fatigued easily and has difficulty writing. So what would be your intervention? Any student, please.
If you want to speak, just unmute yourself, okay? Good morning, everyone.
Morning.
So for the challenges, stairs, provision of ramp should be made available. Then in managing the fatigue, there has to be a structure where breaks are taken in between activities that the child is involved in. But for the handwriting difficulty, provision can be made for a slanted board, or since it's a mainstream school, I think the slanted board should work well.
Great. So yes, sitting adaptation, rest schedule, and writing aids. Perfect. And thank you very much. So also teacher education and peer awareness can also, because in mainstream school, people will laugh, they will make jest and make school very unpalatable for this individual. The experience will not be something to write home about, especially in mainstream school in Nigeria. We all know that. So the outcome will be to improve participation and patients' confidence in your treatment outcome. All right. In our advocacy and leadership role, because in school program for this individual, we as OT, we have to take a lead role, because they call us jack of all trade and master of none. Yes, we have a part of us that is a teacher, an administrator, clinician. So we have to put these goals into use in schools by promoting inclusive policy. Some of these things that teachers don't know, we bring the policy to them, let them see it and understand, because many teachers or the school administrators don't know about the policy that support promotion of inclusivity in school. So we create this awareness, especially on the OT days, on a month like this, the disability awareness, the rare disease awareness. We promote this on your social media. You don't have to leave home if you can't. You can do it in your local churches, in your mosque, wherever you are. Talk to people about it. Then research. Some of you are writing paper at the end of your program. This is a ground where you can maybe use as research topic. Go to all these schools, create like a questionnaire to ask questions about their knowledge and awareness of inclusivity in school. I'm not sure if this has been done by people in the past, but this is a ground where you can research on. Then you start collaborating with other people, doctors, nurses, to get involved in school awareness for this individual. That's where we can take lead role and advocacy as occupational therapists. So my recommendation for Nigeria will be to integrate OTs into school health systems. I know we have clinic in school. I don't know if we still do have now. We have school clinic where we have a nurse. There is an office where if you have injury, they'll be able to dress your injury or give you some medicine. I don't know if we still have some of those. So this has to be integrated into OT. OT has to be integrated into the school health system and make the people in charge aware. Then improve accessibility in school, government and NGO partnership. Like we have the Muscular Dystrophy campaign in Nigeria, partnering with state government, local government, and federal government, and some of us too, who will be coming out to create our own NGO. Of course, I know some people are already nursing the idea. Yes, so this is where we can partner with the government to ensure that the right thing is done for the individual in school. All right. And in conclusion, we can't do without each other. We must all work together. So inclusive education is very essential because the children are the leaders of tomorrow. As we always say, if they must be the leader, then we must take education very seriously. So Nigeria needs stronger school-based rehabilitation system. We know that some people are already doing school-based rehabilitation, like they call it school facilitation for autistic or non-verbal students, but I'm not sure we already have school facilitation for people with muscular dystrophy. If we have for people with autism, people with cerebral palsy, then we should also start thinking about that for muscular dystrophy. Collaboration and advocacy will drive the change. There is nothing we can do alone without collaborating. So together we can build this inclusive school system, everyone. And thank you very much for your time. So we take questions and reaction.
Thank you very much, Mr. Femi Arewolo, for that very inspiring discussion.